Thank you very much indeed. Again, it's a pleasure to be with you and talking about a slightly different subject. Between 1992 and 2001, there were only about 4,000 journals publishing biomedical papers, and there were about 3.5 million in 23 languages. But by 2020, 2.5 million biomedical papers were being published each year by 30,000 journals, and that's nearly 7,000 every day. So clearly a lot of papers are being published. So how can I help you get your papers published? Well, let me tell you first of all the main reasons why your papers are rejected. First and foremost, it's poor experimental design. But the commonest reason is the bosses from a meeting like this listen to an interesting paper and then go home and tell their junior staff, I can do better than that, get all the data out, write the paper, and we'll publish it. Well, good luck, because most journals, and certainly the European Journal, we don't publish papers where there's no new message. So if you're reporting outcomes after a 𝗙𝗶𝗆 bypass, then there has to be something new for us to publish that. We don't just publish it because you have a nice series. Quite often the hypothesis is not explained. There's a very poor description of study methods and analyses, poor recruitment, failure to comply to journal standards, and this tendency to overinterpret the results so that your conclusions are not justified by the data. And also because the author is rather unwilling to revise the manuscript after reviews. Now, the European Society and the journal, when I was editor, we recognized that it's not always easy to get your papers published, and so we set up these methods for writing, whether it's a randomized trial or a systematic review and meta-analysis, observational studies and animal studies, and you can go onto the website and that will basically show you the best way of writing up the paper with tips on how to do it and how not to do it. But this probably sums up the simplest way of working out how a paper is written. On the left is the 𝗏𝗏𝗏 criteria, on the right is the IMRAD. So why did you undertake the study? Well, that's the introduction. What did you do? That's the materials and methods. What were your findings, the results, and then what does it mean? And that is the discussion. The problem is that most people's submissions, the introduction and the discussion is way too long, and the details of the methodology and the results is way too short, particularly the methodology. Now, I'll take you through each of the various stages. Never underestimate the importance of your title, as it may be the only reason that somebody reads your paper. No abbreviations, keep it short and informative, and try not to ask a question. Does so-and-so, so-and-so do so-and-so, so-and-so? That's not a very good way to do it. The abstract is vitally important. I always left it to the very end, so I'd write the rest of the paper and the abstract was the last thing. For heaven's sake, adhere to journal style. If you've had a rejection from one journal and you just submit the same paper to another journal and they have a different style, don't be surprised if your paper is rejected. Keywords. These sound an irritation, but they're really important because that often determines what the editor who's assessing your paper uses to assign reviewers. The introduction is not the discussion. Why was your investigation worth doing? Summarize the important background. Has previous research missed an important question? And what is your main hypothesis or question that you are addressing? The materials and methods are vitally important, and they're all listed here. What was the design of your study? Which clinical material was used? What was the intervention or a drug or test that was applied? Have you used the most appropriate statistics? So, for example, if there's normally distributed, you use parametric tests, and obviously if it's not, you use non-parametric tests. And ethics. you must get ethical committee approval if it is required. The discussion is superficially easy. Less experienced authors don't want to upset the doyens in the field, and so they tend to not be controversial. So you tend to get this bland overview of what you found. First, answer the questions that you posed as your hypothesis. Don't simply repeat the results section, and then relate your findings and conclusions to the existing knowledge, and then highlight discrepancies or weaknesses that have not been reported before. Explain what new information you have added. That really makes it clear that there's something new. And long discussions do not make them good discussions. Now, I'm lucky. When I publish, I'm tending to publish in English-speaking journals, because I'm being a native English speaker, that makes my life very easy. But journals recognize that it's not so easy for non-native English speakers. And if you've got a good paper, we will help you rewrite it to put it in good words. But please don't find a paper and think, well, actually, that discussion, that's similar to my one, and just lift it and put it into your paper. Because we have electronic systems warning of plagiarism, and it will be instantly picked up. And it's not deliberate, it's an innocent attempt to try and at least get good English, but you'll be accused of plagiarism. The references, make sure you use the style preferred by the journal, that they're relevant, contemporary, and make sure you've read them. What are the reviewers looking for? Well, first of all, they're looking for data mismanagement and falsification. They're looking for redundant, which means just repeating the same study with no new findings. Salami publications, what are they? Well, I'll give you an example. A paper might be serum selenium levels in patients with aortic aneurysm in one paper, and then the next paper will be serum nickel levels in patients with abdominal aortic aneurysm. That's salami publication. You're taking the same database and basically chopping it up into as many small pieces. You will be found out very quickly. There are conflicts of interest affecting the author, conflicts about the role of the funding body. If you have had a study that is funded by, let's say, industry, whether it's a randomized trial or a registry, they should have no say in the final version of the paper. And it should clearly state in your paper that the funding body had no influence on the final version. And you need to avoid bias, because the reviewers are really clever at finding it out. And I'll give you a good example. Let's take it that these are 14 thoracoabdominal aneurysms that you've treated with endovascular therapy. As you can see quite clearly, 6 of these cases died post-operatively. That's almost about 40%. But if you decide that your study is going to run from after case 1 and finish after case 7, you now have a 100% survival rate, which is clearly a biased cohort. And what the reviewers are looking for is, for example, if you submit a series that started on some random date in 2015 and then finished in 2018, and you submit it now, we are highly suspicious that you've not included a full consecutive series. Now, there's another issue, and this was a problem when I was a junior doctor, and that was the senior member of your department will often insist on their name going on the paper. Or you might say to a friend, you put my name on your paper, and you can put my name on yours. Beware the perils of the silent author. Because if you put your name on a paper, you are now vouching for the integrity of that paper. And if it is found to be fraudulent, you are equally guilty of fraud. And this was a famous case in the UK. This gynecologist claimed that he had transplanted an ectopic pregnancy and then reported a 3-year trial, separate trial of hormone therapy for recurrent miscarriage, and they were both published. Neither of these studies took place. They were fraud, and Pierce was exposed and fired. But his boss, Jeffrey Chamberlain, was the second author on both studies. Chamberlain was actually the editor of the journal, and he was president of the Royal College of Obstetricians and Gynecologists. And he was forced to retire and resign all his professional positions just because he insisted on his name going on all papers coming out of the department. How to deal with reviewer comments? Prepare them. Sometimes the reviewer is wrong. Be tactful. Avoid making responses when you're angry, and make sure you have another look before sending. And never call the editor once the decision is made. Tips and tricks. Most journals will now not publish case reports. They're never cited, and so they're a waste of space within a journal. But there are clever ways of getting around it. So in the European Journal, when I was editor, we introduced a thing called 𝗘𝗴𝗆𝗀, which is a single image, 100 words, and 2 authors. It gets cited in PubMed, it doesn't affect the impact factor, and it fills the white space in the journal, so you get your case report, so it's a win-win situation. You should also look to analyze your data in a different way. Find either, say, lessons learned from 50 repairs of a thoracoabdominal aneurysm. So you're admitting that there was an issue and how you responded to it. And I'll just finish with this example of what I did. I had a series of 135 combined carotid and cardiac revascularizations. But nobody's going to publish that because it's been published before. But because most of mine were done in patients with bilateral disease, that means there's one hemisphere that didn't have an operation. So if carotid disease was really important in coronary bypass strokes, then there should be a high incidence of stroke on the side of the non-operated carotid. There wasn't. It was between 2 and 3%. So all I did was present my data, but I analyzed it in a different way. And that's something your senior colleagues should be helping the youngsters to do, rather than just looking at a bland assessment of the data that you've found. Thank you very much indeed.
Thank you. Thank you, Professor Ross, for this very nice presentation. I want to open the floor for questions, especially from the young. Oh, this is not young. Yes?
Not so young. Ross, thank you very much. You talked about English and the English language and being fortunate that this is your own writing language. You mentioned something about support. We will help you to do it, but what sort of help can you provide to non-English writers?
The European Journal, we made an editorial decision in about 2016 that if you had a good study and there was good science but poor English grammar and writing, the reviewers can spot that there is a good paper there. It's just been written in a very poor way, and we will then help you rewrite. We have language editors who will help you do that for you, or advise you on what to do. So we never reject papers simply because they're written badly or in poor English. If there is good science, your paper will get published.
Thank you. Thank you. And do you accept review articles, by the way, or are these just the invitation only?
No. I mean, review articles are accepted. They're a very common and popular paper that is submitted to the journal, but they have to be different. There has to be something different about your review that makes it better than the review that was in the issue the month before.
And would the editor-in-chief or the senior editor, would they know which areas they would like a review article about? So if I communicate with you and I'm interested in carotid, you would tell me, oh, we would like to review this area. So I can...
For example, in the 2023 guidelines, we have a list at the back, at the end of the guidelines, which lists all the unanswered questions in the management of carotid disease. If you're wanting to look for ideas on research, some of them are more complicated, understandably, but some of them are quite simple to do. So for example, there's virtually nothing published on biomarkers in asymptomatic carotid disease and their role in predicting risk. It's a study crying out to be done. But the reviews, look for niche reviews that have not been done before, or it's a poorly, it's not of great interest. If you keep going for the major aortic ones and the major carotid ones, the chances are you're not going to get published because it's already been done. But always keep thinking, how can I make this review different? And it means, how do you interpret the data differently?
Thank you very much. Great talk. Thank you.
Dr. Adel?
Yes. Thank you very much, but I have a question. There is some subjects in the field of vascular surgery to look at it when it comes to you from outside Europe, to publish it. So
Absolutely.
we have experience in some fields of vascular surgery, and Europe, they have more experience in other fields. So what will attract your eyes from our subjects, from
Right.
our lens?
You actually have a major advantage, because I'll give you an example, and we were discussing it earlier, HIV arthritis, Behçet's disease. We have virtually no experience in Europe, and certainly in Northern Europe. Behçet's is something as we see in people who've moved from North Africa and the Middle East to the UK. So, so you have a great chance to talk about the lessons learned from the management of Behçet's disease.
Yeah.
Don't do this. This is the best way to investigate. This is the best way to manage it. Avoid operating in this phase of the disease process. So you actually have a great advantage over the European people. We are not geographical. Although we're the European journal, we're very happy to take papers from anywhere in the world. So you're more than welcome to submit.
Thank you.
Thank you, Dr. Ross. Thank you very much. We move now. Okay. Dr.
Very quick
Assam?
question. Ross,
Dr. Assam.
one of the things that I feel has accelerated the research and publications, certainly in the UK and in the West, is the development of national registries, vascular disease registries. There is, as of yet, in this part of the world, no registries. I would hope that I can make a call that we can start to work together and develop registries. Once we have registries, we have data.
But again, you've got the advantage here. You've got certain disease conditions that we in Europe don't get, and you can get a more instant clinical overview of what the results are by pooling together as the Egyptian registry on Behçet's disease or the Egyptian National Registry on Takayasu's. If you set that, if you choose the niche subjects that most relate to your practice, that make you unique, you've got an absolute winner in the making. And the registries, you don't need ethical committee approval for registries, because you're auditing your practice.
Thank you for the excellent tips and tricks. It was very useful indeed. My question, there was an era where people, where certain subjects like peripheral arterial disease or like diabetic feet, in particular category of people like diabetics, like hypertensives, like cardiacs, is this still accepted as a benchmark to submit papers in? Or it's not appealing for the journals?
Do you mean if you've got an interest in hypertension, would we be interested?
No. Peripheral arterial disease, what's مثلا tibial vessel disease in diabetics? Does that categorization with a special category of patients, non-risk, high-risk group, is of interest?
Oh yeah, I mean, if I understand you right, I mean, in mainland Europe, we have a plague of diabetic vascular problems. So it's one of the most topical and studied. Now, so that there are lots of people have written about the role of angioplasty in people with tibial disease and diabetics. So you would have to come up with something that made it different to the ones that we've already got. Okay?
Yes.
You've been sabotaged again. Sorry, I can't hear you up here, really. That microphone's got an issue. By the way, I should say, I made a mistake with the thing. You do need ethical committee approval to set up a national registry, but each individual centre doesn't need to have a separate ethical, or that's the rule in Britain anyway.
Right. So, first of all, can I congratulate you on the clarity of your thought? I review for a couple of journals, vascular journals, and the majority of the papers have mistakes like what you've mentioned, but an awful lot of them have mistake in the structure of the study, which is like lack of randomization or particular bias and try to get their own conclusion. Could you please touch on the structure of the research itself?
What you mean, how studies are designed?
Yeah,
Well, let me put it this way. having done several single-center randomized trials, they are incredibly difficult to do because a single center struggles to get enough people. The big funding bodies are now getting more and more difficult to get multi-center randomized trials so that there are substitutes coming in. So that, for example, in Sweden, they use their 𝗦𝘆𝗴𝗃 national registry for the purposes of using propensity scoring and even randomized trials within that. I may have missed the impetus of your talk, but I mean, case reports and everything are not going to get published, I'm sorry, unless you use what I guided you on and being canny and careful. Okay, yeah, I see. Yeah, retrospective. Right, retrospective studies is the bread and butter of vascular publishing, along with other specialties as well. But I come back to the basic tenet. If you have an interesting retrospective study that has got a new message, that is fine. If it's a retrospective review of tibial angioplasties in diabetics, and we'll go, that's very interesting, but the results are no different to what we've already got in the literature. You will find a journal that will publish it. It'll be a lower impact factor, or you'll probably have to pay for it. But if you're wanting to make your publications ever better quality and to get the pleasure out of that kind of publishing, you need to be more careful in the way you do it.
Thank you, Dr.